Hello again. My name is Shannon Carroll and I'm a psychiatric nurse practitioner, and I'm going to do part 2 of our series, and we're going to discuss treatment of depression. So the learning objectives today are going to be to look at who is most at risk for depression. We're going to look at the neurobiology of depression. We're going to look at treatment decisions and how they are made, and that kind of follows through from our last segment. We're going to learn about the different classes of antidepressants, and we're going to focus mostly on first-line treatments. We're going to learn a couple of clinical pearls for each medication so that we can use that to teach our clients, and then we'll do a case study and some questions. So who gets depressed? The answer to that is that we all get depressed. Everyone experiences sadness, and feeling, not great at times. It's different though than clinical depression. And so let's talk about clinical depression and who's most at risk for that. The CDC reports that 1 in 10 adults experience clinical depression. Groups that are disproportionately impacted by depression include those living with chronic illness, women, especially women during postpartum period, people ages 45 to 64, Black, Hispanic, and non-Hispanic minorities, and those experiencing environmental stressors, loss, or trauma. And poverty can be one of those environmental stressors. The neurobiology of depression is a fascinating subject to me. We have a lot of new technologies that are able to look at the brain during a depressed state and during a healthy state. That's fairly new, and it gives us a lot of information about what's happening. On your screen you'll see a PET scan of a healthy brain as compared to a depressed brain. You can see that the depressed brain has much less going on. There's a decreased electrical current. Less of the brain is being utilized, whereas a healthy brain is lit up almost everywhere. There are neurotransmitters that balance our mood and our functioning and our feelings of relatedness to each other, and the theory is that those are dysregulated when we're depressed. 3 of the primary transmitters that are implicated in depression are serotonin, which is involved in our feeling of well-being and is implicated in anxiety and depression. Norepinephrine is another neurotransmitter which helps us with concentration, attention, and energy, and this is implicated in anxiety. Dopamine is involved in reward and pleasure, in motivation, in cognition, and memory formation, and it's implicated in psychosis, ADHD, and depression. When we decide to treat with an antidepressant medication, we are looking at a group of targets that we want to reach. One is the mood itself, the depressed mood, and then some of the other physiological signs of depression, including sleep-rest disturbance, appetite changes, irritability, impaired concentration and memory, as well as anhedonia, which is the inability to enjoy or have fun even in entertaining environments. So say you used to love to ride a bike, now you ride a bike, you feel nothing. That's anhedonia. But let's look at antidepressant mechanisms of action. Most antidepressants do 2 things. They block the reuptake of neurotransmitters, and they also sensitize receptors located on the cell membrane of the postsynaptic terminus. There's a graphic on your screen that can help you understand that. So what happens is, when we block the reuptake of neurotransmitters, we allow for that neurotransmitter to stay present longer in the postsynaptic cleft. That's the area between those 2 synapses. There's an arrow pointing to it. That's where we want the neurotransmitter to stay, okay? And then on the postsynaptic terminus, the antidepressant sensitizes the receptors there, which makes it more responsive to the antidepressant. So it has 2 effects. Sticks around longer and is and then the receptors are more activated by it. Okay? What happens when we block the reuptake? We get more of the neurotransmitter present, the receptor cells get more sensitive, and then after a period of time, we start to see an improvement in mood and an improvement in the symptoms of depressions. Now, this is a great thing for depression. It is not such a great thing for people with bipolar disorder. It has huge implications for mania, and I'll tell you why. Because in manic states, people are having flushes of these neurochemicals. If we then add a medication that increases the amount and the longevity of that medication, it's very likely that we can cause either a hypomanic or a manic state. So that's why diagnosis of depression is very important, and getting the diagnosis correct so that we don't miss bipolar is very important. As a therapist, this is a great place for you to think and work with a client. If a client leaves, gets on an antidepressant, and then comes back and appears to you hypermanic to manic in a few weeks, chances are they may be experiencing an onset of bipolar or a triggering of mania, and that would be a great time to coordinate with the prescribing clinician. So we're kind of all in this together, since follow-up appointments are 1 to 2 weeks out, sometimes later than that. Therapists will be the first person to see this actual reaction. So how do we choose a medication? I know in our last series I gave you a flow sheet, and it looked really pretty, and it's kind of told you if this, then this. But there's also a lot more things we need to think about. We want to look at their current presentation. Are they exhausted? Are they anxious? We also want to look at historical response. Have they ever been on meds before? And if they were those meds effective, or did they have horrible side effects? Did the patient experience mania when they were on that last med? We also want to look at genetics. Is your mom anxious, and is she on a medication that works for her? Chances are if she is and the med works, it'll also work for you. That's something I love to tell clients. And then also we look at the side effect profile. Lots of clients, especially young people, will say, I can't deal with sexual side effects. Absolutely not. It's a deal breaker. A lot of athletes or people who are image conscious will say, I can't deal with weight gain. It's an absolute deal breaker. I want to feel better, but I won't do that. So that really limits some of the meds we can use, because weight gain is a side effect of a lot of medications. Sexual side effects are a side effect of a lot of medications. But there are things we can do to mitigate those side effects. Let's go on to treatment algorithms, which is a standard way to make med decisions. Not everyone uses them. They're not always clinically indicated. Often somebody will come in with depression that doesn't look like someone else's depression. It has its own unique features. It wouldn't be useful to just follow a protocol for someone that doesn't fit the kind of primary symptoms of depression. That being said, I find treatment algorithms very useful in my practice. Let's discuss the STAR-D treatment algorithms and the TMAP treatment algorithms. So STAR-D, this is pretty much cutting edge psychiatry. Almost every clinic that I've worked at uses this. It gives you a step-by-step approach to how to treat depression. We're looking at just depression, no comorbid conditions, basic depression. STAR-D recommends, after multiple controlled trials, that we follow this algorithm. We would start with citalopram. We would maximize it to the highest dose possible. If we're still not seeing it work well, we would move on to step 2. And if that doesn't work well, we would move on to step 3. Okay, so it's pretty simple. Someone comes in with classic depression. Let's start with the STAR-D treatment protocol. The other one is Texas Medication Algorithm Project. There's a huge push to have all treatment standardized, which makes sense, except for when a client is presenting in ways that doesn't fit kind of the norm. this is just another flow sheet of ways to decide. And this one gives you a little bit more leg room to start with a medication that you prefer and then move through different treatment algorithms. So with antidepressants, there are first line, second line, and third line treatments. First line treatments mean these are the ones that have been shown to have the most efficacy, the least amount of side effects, and the safest when a client overdoses on them or uses them incorrectly. And the ones that are most commonly used are called SSRIs, SNRIs, and NDRIs. Let's start with the SSRI, which is the classic treatment protocol for depression. What it does is selectively inhibits the reuptake of serotonin. So it goes to the receptor site, blocks it from taking the serotonin back up, which means the serotonin stays there longer, receptor sites have been activated and are more responsive to serotonin, and it causes the physiological effect of bringing down depression. It helps control anxiety, it helps control obsessions, and it can return a sense of well-being. The problem with it is it takes 2 to 8 weeks to show efficacy, and it's more like 8 weeks before you see much. Okay? Side effects include nausea, agitation, headache, sexual dysfunction, and it may cause weight gain. Several of them may cause weight gain, which, as we already know, is a deal breaker for some people. SNRIs are also considered first line. They selectively inhibit reuptake of serotonin as well as norepinephrine. What this does is it helps relieve depression, works very well for pain, and it also reduces fatigue. Whereas SSRIs often are known to cause fatigue, SNRIs knock out fatigue. They have similar side effects including GI upset, anticholinergic effects, sexual side effects, and they've been known to actually cause anxiety and insomnia because they're kind of activating. They're peppy. It's like drinking an extra cup of coffee every day. The major benefit for them is that they do not cause weight gain, or if they do, it's much, much less. Let's move on to NDRIs. There's only one medication in this class. I'm pretty sure everybody knows about it. It's called Wellbutrin, and it selectively inhibits reuptake of norepinephrine and dopamine. What that does is reduces depression, anhedonia, it reduces fatigue, and here's the key, it reverses sexual side effects, and it also doesn't cause sexual side effects if it's the only medication that you're using. So, it would sound like an amazing drug, except for the fact that it can bring about some pretty heavy anxiety because it's also a pepping agent. It's like an extra cup of coffee. And it's also contraindicated in alcohol use disorders and eating disorders because it lowers the seizure threshold, which means you are much closer to having a seizure on Wellbutrin. When you add alcohol or an eating disorder, it kind of amplifies that effect. Oops, excuse me. The best things about it are it does not cause weight gain, and it can also be added to almost any other medication to reverse the sexual side effects that the original med might have caused. All right, here are the basics that everyone kind of uses. They're the gold standard for starting depression treatment. Citalopram, as you see there, is the #1 med to start if you're using the STAR-D trial, right? But we also have Lexapro. Great thing about Lexapro is it works faster than other medications. You actually may see a benefit in 2 weeks, whereas almost every other med has to get to 4 to 6 weeks. So often we start with that. Works for anxiety, works for depression, and it works quickly. Here's the problem. Often causes weight gain. People are afraid of the weight gain, and so they may feel like that's coming on and then just stop the medication. Also causes nausea, and you have to kind of push through the nausea in order to see the beneficial effects. If people aren't willing to do that, then there's often treatment failure. Zoloft is a great med as well. It works for depression, anxiety, autism symptoms, PTSD, and it also works for premenstrual dysphoric disorder. It's the #1 go-to to work with the female cycle. And you can also dose it during the luteal phase of menses and treat PMDD. So that's a great med. It has a bit of a pepping effect, sort of like Wellbutrin, and so some people feel stimulated on it. Prozac. Prozac has been around forever. It was one of the first. Everyone knows about it. It has a lot of different indications, including eating disorders, major depression, OCD, PMDD, which is premenstrual dysphoric disorder, and it helps treat the symptoms of autism. Excuse me. Many people also find that stimulating, which is interesting because it is indicated to treat anxiety, and yet it can feel overly stimulating. We also use Prozac when someone is trying to come off of another medication that has an uncomfortable withdrawal effect, like Effexor. If someone was coming off of Effexor, I may add Prozac to kind of titrate between the two to make it less uncomfortable. We're going to keep going with the SSRIs. There's 2 more. Paxil, and that medication is good for depression, anxiety, PTSD, and bipolar depression. It unfortunately has multiple drug interactions and a very strong discontinuation syndrome. People also find it very fatiguing. So you could take it at night to help with the fatigue, but a lot of people discontinue the med because it's just too fatiguing for them. Luvox or fluoxamine is also a medication that's available for depression and OCD. It does not cause sedation. It has no weight gain. It has no sexual side effects and a long half-life, so it's a good med to use. And then one of the newest medications is called Vibrid. It's not technically an SSRI, but it does work on serotonin. It has 2 different effects. One is selectively stops the reuptake of serotonin, but also it's a partial agonist at serotonergic 5-HTT receptors, which I guarantee you we're not quite sure what that means yet, but it's supposed to be important. Doesn't cause sedation, unlikely to cause weight gain, and it has decreased sexual side effects. Let's go back to Wellbutrin for a minute. Wellbutrin has indications for depression, smoking cessation, chronic fatigue, and it's also most recently been used to treat ADHD. It does work quite well for that. I have a lot of people on it for that who have some depressive symptoms as well and who have not completed neuropsychological testing for an actual ADHD diagnosis. All right, let's move on. The next class of medications that I would like to talk to you about briefly are called SNRIs. I mentioned them earlier, and now I'm just going to get into a little bit of the detail of them. Cymbalta, which is also called duloxetine, works on multiple different pathways, and it is good for depression. It's also good for diabetic neuropathy, fibromyalgia, anxiety, chronic musculoskeletal pain, stress urinary incontinence. Whenever you see a star on your screen, by the way, it means that the FDA has not approved it for that indication, but we still use it for that indication. I see Cymbalta often in my practice, and often for things where it's like a last resort. We don't know what's wrong. We don't know where the pain's coming from. There's nothing medically indicated. Let's try this medication. Maybe it's anxiety. Maybe this will help. It doesn't cause sexual side effects. Fatigue is rare. It does cause lots of GI upset, and it is very difficult to come off of. We pretty much have to reduce the dose by half and then leave it for a while and then reduce the dose by half again, and in each step the client goes through a little bit of discomfort. Venlafaxine is one of the newer meds. It's really quite useful for depression and anxiety, panic and social anxiety, OCD, neuropathic pain, hot flashes, ADHD, although I have never seen it used for that. But it also has a similar discontinuation effect. Missing even one dose is very uncomfortable for clients because it has a short half-life, which means you have to reintroduce it to your body every day at the same time, or it'll be completely out of your body by the end of the day, and it's uncomfortable because 1 minute you're up and then you're down and then you're up and then you're down. Basically, that's how it works. Has to be taken with food, doesn't cause weight gain or sedation. The next two medications I find quite humorous because the indications they are for, they don't work for at all, but the side effect profile is such that they're very useful for other stuff, and I'll explain. Trazodone. It has an indication for depression. It does not decrease depression. At least I have not seen it. All of the lectures I've gone to have said the same thing. However, it has a very strong sedating effect, and so people have started using it for insomnia. It works great for insomnia, not for depression. Mirtazapine or Remeron, same thing. Indicated for depression, does not really work for depression, however works very well for insomnia, and has the added bonus of it will cause weight gain, and so it's very useful to give to patients who are underweight. It puts on weight quickly, and some people really need that. Okay. Second and third line medications, I just want to go over very briefly. It's rare for them to be in practice, and I would say usually this is in the realm of a specialist to use. They're older, and their side effects are heavier, and some of them are deadly. I'm not saying they're not being used, I just rarely use them. Second line would be TCAs, and these, an example of one is Elavil. It increases the levels of norepinephrine and serotonin. It also blocks the action of acetylcholine, which is another neurotransmitter. One of the common uses is for OCD. It's kind of the gold standard. It's the go-to for that. It's also used off-label for enuresis in children. So when children have reached a certain age and they're still wetting the bed, they may try a very small dose of this. It also works for extreme pain. They have less favorable side effects. They can kill you if you overdose on them. They require close monitoring, and they have multiple drug-drug interactions. Third line medications would be MAOIs, and an example would be phenelzine or selagalene, I think it is. I always struggle with that one. Let's just say phenelzine and leave the other one alone. It works by inhibiting an enzyme called monoamine oxidase. So that enzyme removes neurotransmitters. It helps break down neurotransmitters. What we do is we block it, and it leaves the neurotransmitters present for longer in the brain, and you have more access to it. It's good for atypical depression, hypochondriasis, dysthymia, highly treatment-resistant depression. And here's the side effects. It's rarely used because it has multiple medication side effects, and it has multiple food side effects. You can't mix it with multiple foods. To do so would risk a hypertensive crisis and could land you in the emergency room. So I'm not saying they're not used, just a lot to think about when using them. So let's get back to some patient teaching that you can do in therapy with your clients, okay? Because one of the things that happens on a regular basis is when a patient starts a medication and they don't see an effect right away, or they wait the entire med trial and they're still not seeing effect, there can be some hopelessness that goes with that. And so patient teaching is really important both in the therapist's office and also in the psych provider's office to remind patients that one med trial is nothing because we have several ways to go about it. So it's good to know what we would do if the client was experiencing either partial response or no response at all. We'd want to instill hope and explain that we're just, at the tip of the iceberg. We have many, many more ways to go. So when someone comes in and we've done an appropriate med trial, they're up to 8 weeks, we're not seeing an effect or only a partial effect, I start to think about what's next. We can optimize the dose, which means bring it all the way up to the highest level indicated. We can also look at adherence. Is the client taking it every day? Are they taking it the right way? Are they splitting doses? Are they forgetting doses? And work quite a bit on figuring out a way to make it part of their routine, and also looking at some ambivalence. So in therapy, I would always want to know, is there some ambivalence about taking meds, and what should we do about it? If it turns out that we're at the optimum dose and they really are med compliant, then we go down to step 2, which is we can change to another antidepressant. And I often titrate between back and forth, so slowly down on one while bringing the other one up. It's much more comfortable than just stopping and then having a period of washout and then starting another one. You can do that with SSRIs. We can either start a new med in the same class, or we can switch them to a med in a different class. Like, let's say they're on Lexapro for quite a while. They've tried several different SSRIs. They're having the same effect. My next move would be to try Effexor, which is in a different class, has a different mechanism of action, and is indicated for treatment of the same condition. We can also add a second antidepressant. This is called augmentation. So, remember when we were talking about Lexapro and the person was experiencing some sexual side effects, right? Did we mention that? I think so. Anyway, you can get sexual side effects on Lexapro, right? We could augment with another medication to try and fight that. Wellbutrin would be one of them. So leave them on Lexapro, augment with Wellbutrin, and hope that the person remains depression-free and is able to have full sexual function. The fourth step would be to add a non-antidepressant, okay? And so you have a partial effect. Augmenting didn't work with a second antidepressant. Let's move on to kind of the heavy hitters. We can add a non-antidepressant like lithium, or a mood stabilizer like lamotrigine. We could add a psychostimulant, or we could also add an atypical antipsychotic. I'm sure you see the ads everywhere. Just add a little Abilify. Some people really do that. Or a very low dose of Risperdal has also been shown to help with treatment-resistant depression. Here's the black box warning that comes with every antidepressant medication. I put it on here because I wanted everyone that sees this to be aware that this still exists. It's something that I talk to with clients that are under 24. It's very important to know. The FDA wants it on everything. However, I do have to say that some of the research used to create this black box warning is controversial, and there's been a lot of discussion about it. But as it stands right now, in every session I discuss with clients, this medication may make you feel worse rather than better, at least at the beginning. It's been known to cause increased suicidal thinking and impulsivity in some, and can we please create a safety plan to address it? And that's how you start, is you created a complete safety plan with the client and make sure that they're on board with it before trying this. Some patient teaching that you can do in therapeutic sessions and that I would do in a psychiatric session is discuss how long it's going to take for a medication to work. Remember that clinical onset is at the absolute earliest 2 to 4 weeks, and usually more like 6 to 8 weeks. So the client has a period where they're going to still feel a little raw, but we can instill some hope in that they're finally getting the help they need, and hopefully that can help sustain all the way through to the 6 and 8 week periods. I love to tell people that we are treating symptoms and that we are not healing them with psychotropic medications. Healing really does happen in therapy for almost every mental health issue. Medications just kind of dumb down the symptoms so they make life a little more manageable, and so you have more access to your emotional range in therapy, okay? All medications have side effects. There's no way around it. Treatment failure is usually because of side effects, and so encouragement and setting realistic expectations is very important when we're working with clients, both in therapy and in the psych session. I like to tell people about what happens if they stop medications early, okay? Medications stopped before 6 months have a very high chance of relapse, up to 50% chance of relapse. So that means if you are feeling a good effect, please don't stop your meds early. You know, it's sort of like antibiotics. Some people take antibiotics, they feel better, they stop taking them, and then the infection comes raging back, similar to an antidepressant. If you stop it when you just start to feel better, chances of rebound depression are up to 50%, and often it comes back very strong. What else? Antidepressants are not addictive. I've heard that 3 times this week. Will I be addicted to this? No, you will not. And usually you do not need to be on it for life. A successful med trial is 6 months long, and often we extend it to a year, and then we try a period of medication free and see if you still need to be on it. Important to also discuss is substance use while trying a medication. This one is difficult because you want to avoid in any way sounding judgmental. I like to discuss a harm reduction approach and just explain that alcohol and marijuana and other substances really do interact with antidepressants. They can cause increased depression, they can cause synergistic effects of the medication. You're more prone to blackouts. It's like having 3 shots of whiskey already and then adding more alcohol on it. So it's very, very dangerous to do, especially on Wellbutrin, which lowers your seizure threshold. 2 more points. A client really should never change their dose or discontinue their medication without working very closely with their treatment team. And the reason is because some meds you can just stop, and they have a very long half-life, and they really won't feel this discontinuation syndrome. And other meds have a profound and very quick discontinuation syndrome, which could land somebody in the hospital, really. So it's good to know that it has to be done with the treatment team, okay? And the last thing is, I love holistic approaches to medicine, and that being said, many herbal supplements interact with psychotropic medications, including St. John's wort, SAMe, 5-HTP. They're all very useful, but when you're going to start and commit to a med trial, they have to stop because they interact. They either increase the antidepressant, or we'll see effects where we don't know where it's coming from. Is it the supplement or is it the medication? And so it's best to have only one medication on board at a time. Let's do a case study. We're almost done. All right. A 30-year-old African-American client of yours has decided he wants to try medications as an adjunct to the therapy he's been doing with you. He's been in treatment for 3 months. You guys are making progress, but there are still physiological signs of clinical depression. Currently, he has multiple psychosocial stressors, as well as recently losing his job, and he is the primary caregiver of his elderly mother. He denies any substance abuse. He has never been on medications. His clinical picture includes anxiety as well, and he wants to remain in therapy with you and just add a medication to it. Based on the STAR-D algorithm, what medication might be started? Okay, question 2. How long would it be before the client starts to see some reduction in the symptoms from the medication? Your patient has never been on medications. What patient teaching is important for him to know? And then here's some more questions. Your client reports that the symptoms are getting better. He's able to function at work. He doesn't feel depressed. However, he's having sexual side effects. He's feeling a decreased libido. He's having difficulty ejaculating, and he's also having trouble maintaining an erection. As we know, that can be a side effect for many antidepressant medications. He wants to know from you what he can do about it. What would you say? What might the prescribing clinician do to treat the side effect? And the last question is, if a medication is added to help, but then causes anxiety, what might a third option be? Okay, thanks.